And we are moving forward to Professor Giammaria Fiorentini, who is going to speak about advanced pancreatic cancer treated with combo therapy with modulated electrohyperthermia and chemotherapy, a new hope. I think this is also a very interesting topic. So please, Professor Fiorentini, if you are there. Let's see.
Okay.
Yeah.
Okay. I try to. Okay. Yeah. Okay. First of all, I would like to thank all the scientific committee, and we are a little bit unhappy because we would like to be with Elizabeth in Spain all together, but we hope for the future. Now we are talking about a severe disease that is pancreatic cancer, especially pancreatic ductal adenocarcinoma, that is more than 90% of the tumor. And you see what happened in the world. In the richest countries, we have a high increasing incidence of this tumor. Exactly, we don't know, but probably the rich fat foods, alcohol intake, other toxics, and also the age of the population could be one reason for this increasing tumor. You see do you hear me? Do you see me?
Yes, we can see and hear you.
Yeah, yeah. You see, stage 3, the tumor has spread near the blood vessel and may or may not have spread nearby by lymph nodes, but the cancer is still limited. Okay, unresectable. You see, the vessels have been engaged. This is an enchasement of the tumor. Stage 4 means that we have metastatic disease. And this is the sad situation. You see that even the tumor is resectable. We have a short median survival with a small lesion 2 years. But I present data on third and fourth stage. You see the situation is completely unsatisfactory. Well, you know, hit the tumor, cause cell death, damages cancer cell, means a more expression of additional protein, cell release antigen, then dendritic cell pick up and transport antigen in the lymph node, where there is the activation of the immune system, identify cancer cell to immune system, and so this active T cell increasing blood flow, and there is the promotion of perfusion, and so the attack of T cell and killer cell to the tumor. This is the successful activity that hyperthermia induce. This morning we have already seen this aspect. Why our study? Because an increasing number of studies report beneficial effects of regional hyperthermia in association with chemo and radio for the treatment of pancreatic cancer. In particular, recently, the use of modulated electrohyperthermia resulted in increasing survival and tumor response. Here you can find some data, recent data, our data from my colleague Sarti and by in which you see that we compare. This is observational study, and I mean that observational study is important even if we don't have randomized one, because in this kind of tumor, generally, and is a reality that chemotherapy is always the same. So even in different time, the changes in the cure are not so significant. For this reason, observational studies are important. In our study, we adopted modulated electrohyperthermia plus radiotherapy or chemotherapy with gemcitabine-based regimen versus without hyperthermia. We adopted modulated electric hyperthermia with an Oncotherm machine twice a week, and the same in these previous studies. We treated 32 patients here, more than older patients, more than 65 years, and here a little more patient, 106. The previous data is that overall survival was 18 versus 11 months in untreated with hyperthermia patient, and the PFS was advantageous, 1 year versus 5 months, the same in our previous study. And was very interesting is that the tumor response, disease control was clearly in advantage of hyperthermia in these two studies, and the toxicity was not very mild, not significant. Other author, like you see here, Rikishi in 2019, tried chemotherapy with gemcitabine or FOLFIRINOX regimen plus modulated hyperthermia with ICHS 25 patients. The overall survival was about 16 months with PFS of more than 1 year. This is of interest. Ono in the same year used the same chemotherapy as I told before. This is the standard treatment using thermotron machinery, treated 20 patients, and about 41% of patients were living at 1 year, at 2 years. He had a not slightly percentage of surviving patients. At 3 months, the disease control rate was about 60%, at 6 months 45%, and 1 year 12%, 18 months 6%. Mebayashi treated patient with fluorouracil gemcitabine plus regional hyperthermia versus chemoradiotherapy. He used the same thermotron, and you see treated 13 patients, and at 1 year the overall survival was 80% versus 50% in not hyperthermia group. This German group, Schoep Lechner, treated with gemcitabine plus cisplatin and regional hyperthermia. They use BSD machinery and treated 27 patients. The PFS was 6 months, and the overall survival more than 1 year. Disease control rate was 50%. Maluta treated with the same BSD machinery 68 patients with a median overall survival of 15 months versus 11 in the patient not treated with hyperthermia. Volovat adopted on 26 patients GEMOX and modulated electric hyperthermia. And he has a disease control rate 71%. Ishikawa and Oguri treated patients with the same combination chemotherapy with gemcitabine plus regional hyperthermia versus for Oguri chemoradiotherapy. Okay, small number, but you see that the median overall survival was about 18 months, and the median overall survival was 9 months versus 5 months. It was a little bit significant, and the same, the PFS was a double, and all these studies had no more toxicity. On these studies, the aim of this report is to compare outcome of chemotherapy alone or in association with modulated electric hyperthermia for the treatment of advanced stage. This was an observational multicenter retrospective study. Data were collected from patients with stage 3-4 that were treated with chemo alone or in combination with modulated electric hyperthermia in the from 2003 and 2019. A total of 158 patients were included in the study, out 270 patients screened in 4 Italian hospitals. 37% of these received chemo plus modulated electric hyperthermia, and 100 only chemotherapy. Chemotherapy was mainly gemcitabine-based regimen in both groups. In the patient receiving modulated electric hyperthermia, this was performed using an AH2000 plus device, applying radio frequency current of 56 megahertz as carrier frequency that was modulated by time fractional fluctuation. The energy was transferred by capacitive coupling with precision impedance matching. The hyperthermia protocol included 3 modulated electric hyperthermia treatments for week for 2 months, starting at a 60 watt power for 40 minutes. Following treatment were performed by increasing the power up to 150 watts and the time to 90 minutes in 2 weeks. Modulated electric hyperthermia was administered after chemotherapy or within 48 hours in order to couple the high drug blood concentration with the modulating electric hyperthermia and optimize their synergy. This is the characteristic of the patient. It is well balanced, but please note that in the group that received hyperthermia, non-metastatic was less than only chemo, and metastatic was a little bit higher than chemo group. So, I mean, this group was a little bit worse than only chemo. And again, in this group, a large percentage had received multiple chemotherapy. GEMOX was the main schedule adopted, but you see that the histamine was present in the same. Overall, and progression-free survival were better for the chemo plus modulated electric hyperthermia group compared to chemo group. I mean, about 20 months versus 1 year, and progression-free 12 months versus 3 months. The association of modulated electric hyperthermia resulted also in an improvement of tumor response with disease control of 95 versus 60 about at 3 months. Toxicity was comparable in the 2 study group, and the modulated electric hyperthermia related adverse events were limited in 8 patients presenting G1-2 skin burns. This is the survival probability curve. You see that there is a detachment of the 2, and at 2 years you see that there is about 58% of living people here, 38 here, and the PFS are the same. Is interesting. At 1 year you see that is about 78% compared with 38%. Again, disease control was better for the combination with modulated hyperthermia, that is about 90% versus 60% at 3 months. Here we have an increased percentage of partial remission instead of a large number of progression disease in the only chemo group. The addition of modulated electric hyperthermia to systemic chemotherapy improved overall and progression-free survival and the local tumor control with comparable toxicity. On the basis of the study and the other numerous studies in the literature, it now seems time to organize an international randomized trial to evaluate the utility of electric hyperthermia in this serious disease. Thank you very much for your attention.
So thank you so much, Professor Fiorentini. Very, very interesting. Your results, I think, is an important topic because we have bad results in general in pancreatic cancer. So I think it's very interesting improving the survival. So I will wait for some questions because I'm sure we will have, but I have two little questions. One is that at the beginning you show that you used only 8 treatments with modulated electrohyperthermia in your previous study, only 8 treatments?
Yeah. As I told before, I think that is very useful to carry out observational study, because it's really different to perform randomized trial. And so we collect data from it's many years, and we compare what happened in the group that we have treated with chemo alone or chemo plus hyperthermia. Sometimes the selection is not easy, because generally patients arriving for hyperthermia is far advanced. And so, as you see, out 270 patients that we have observed, about half have been considered for the treatment for this reporting. And but I am convinced that with the new criteria for new trial and adopting more attention in the selection of patient, and adopting more modern criteria of staging in the relapsed disease, is possible to carry out something of useful for us.
Okay, and another question, because that is always a question for me, for my patients. So you treat the patient for 2 months, and then do you wait for the CT like 2 weeks more, or do you make the CT just after those 2 months? So do we need to wait a little bit after the treatment, or how many treatments do you do before that CT scan to see how is everything?
We perform a CT scan in the beginning for when we recruit the patient, and exactly at 3 months independently the duration of the treatment. And then every 3 months we perform a CT scan. Obviously, if it should be necessary for a clinical reason, we anticipate and we try to perform other CT or RMN, but generally we decide to maintain 3 months. Okay, could be the interval could be a little bit gap, a few days, but in order to have a clear data, we maintain a strong rule for checking this patient.
Okay, so you usually don't wait without treatment for 1 month or something like that to have the CT, because you said that you treat for 2 months, and then if you have the CT, because my concern is again the same that in brain, that maybe if we wait in that time we are waiting, we are losing time for treatment.
Yeah. No, we try to organize, and the patient that we have considered, we don't have lose time. We are a little delay, but substantially was acceptable. This is another reason for which we did not include such number of patients, because we carry out this study in 4 hospitals, and sometimes it's not the same. Okay, perhaps we are a little bit advantageous because we are medical oncologists, and so it should be easier for us to have a CT scan or to combine with chemotherapy, probably. And at the same, we can do chemotherapy during the hyperthermia. This is an advantage, and sometimes this is useful for the patient and also for the hospital.
Okay. Okay, so thank you so much, because sometimes I would like to go on with treatments, because, you know, if you are at the private practice, you have the bad part that the patient wants to know what happens before going on paying, and at the public part, you have the problem with the gaps for the device that you don't have enough space. So thank you so much. I think it's really, really interesting. So I think we don't have now more questions.